Am I on the, is that okay, Candice? You ready?
I'm ready.
You ready? Okay. We'll go ahead and get started because the introduction and housekeeping will give us a couple of minutes. All right, so welcome everybody. My name is Sonia Denny Zulu, and I'm a faculty member in Department of Psychiatry, Child and Adolescent section here at the University of Chicago. And I'm also the chair of the Trauma Interest Work Group Steering Committee and the work group itself. So we are very pleased to continue our series with the Brown Bag Lunch featuring Dr. Candice Norcott, who's my colleague and friend, and she is an assistant professor in the same department as me. And her clinical and research interest involves looking into reproductive health and justice and gender responsive trauma-informed services, particularly for young girls and women. So before we hear from Dr. Norcott, I would like to go over some information about the Trauma Interest Work Group and some housekeeping rules. So the mission of our group is to promote the scientific interdisciplinary understanding of trauma to improve health equity on the South Side of Chicago and beyond. We do this through education, scholarship, clinical care, community engagement, and advocacy. So before we again hear from Dr. Norcott, I think we all been through this before, but please just be mindful of muting and unmuting yourself as needed. For any questions, you can put, I believe we have the Q&A up and available, so feel free to use the Q&A option, or you can raise your hand as a Zoom feature. This event is going to be recorded and it will be available on Mansueto Institute YouTube channel afterwards. If you're interested in joining the Trauma Interest Work Group, the listserv, please visit list.uchicago.edu and selecting Trauma Interest WG. So you can hopefully see it on the slide. And then we will continue with our Brown Bag series in the spring. And we also have the theme for this year, Arts and Resilience series, that will continue in this, also in the spring, where we will have some feature of a film festival and a few other events. So if you're interested, continue to stay tuned and visit the website and to learn more about our upcoming events that are soon to happen. So without further ado, Dr. Norcott, if you can take it over. Thank you.
Thank you. Yes, Sonia has been an advocate, a supporter, in addition, ever since arriving at the University of Chicago, and so have many of you on the call. So I thank you for inviting me. Let me start by sharing my slides. Okay. I'm going to have my eye on the chat. I'm going to be looking, hopefully, at you. If I have any issues with sound or any of my slides, please throw it in the chat or feel free to just let me know. Gesticulate wildly in your screen.
And I'll help monitor the chat, Candice. You don't have to worry about it.
Okay, thanks. Okay, so my talk is called Moving Towards Liberation-Centered Practices in Sexual and Reproductive Health. If I added the reproductive, it would have been really long. So this I just felt like looked better on the slide. And so thank you for having me, and happy Black History Month. I get to be the Trauma Interest Work Group presenter for Black History Month, so I think that's awesome. I do not have anything to disclose other than I have a new version. I have the new version of PowerPoint, and I'm not afraid to use it. So I like to make my slides just look all over the place. I don't like uniformity. And so today I want to start with my guiding principles in terms of what I want to talk to you about. So I want to talk about the guiding principles in the work I do around sexual and reproductive health. I want to talk briefly about what reproductive health is and what sexual health is and the impact of violence, abuse, and trauma on those things. And then I want to discuss a framework and a framework that helps me create services and stay in terms of, walk within my values as I do research and deliver services to the population I work with. I always start with this slide because my talks talk about trauma and include themes of violence at varying levels. So this slide just really serves as an invitation and a reminder to take care of yourself in any way you know how. You may very well have your to-goes and the things that are your tried and true strategies. But if you don't, here are some ideas. Here are 6 ideas for you. I always keep scented lotion not in addition to just having winter dry hands. It's always just a bit of aromatherapy and self-soothing. So whatever is around you, feel free to access it as you need. So guiding principles. So there are some guiding principles that are really core and help and serve as like a compass to the work that I do. And the first, and where I'll start, is Black feminist theory. And Black feminist theory offers a lens through which we can understand the experiences of Black girls and women at the intersection of her oppressed identities. And we anchor, it's anchored in Black girls and women, but as a theory, the idea and the theory remains inclusive, right? And it remains inclusive because like a core tenet of it is when you move forward with the intention of centering the most marginalized, then everyone gets included, right? And so it's not about only being for Black girls and women, but when you create services, when you conduct research, where you think about marginalized identities and make it accessible for them, you can be sure that others will be included in that as well. And so that framework is appealing to me as I think about research, my scholarly work, my teaching, my speaking, and my clinical work. It stresses self-definition and self-valuation as powerful forces. And powerful forces for the individual, but also so that individuals can join collectivities as their healthiest self. So it really has implications for collective well-being as well. So, and I love that. I love that reciprocity. And so, and additionally, within Black feminist theory is the concept of intersectionality, right? The idea that all identities, that all oppression is intertwined and connected. And we can create and think about the totality of the person that's presenting to our research, our clinical work, the meetings that we're in, right? And when I'm talking and when I'm thinking about reproductive health, the concept of intersectionality is particularly important when I'm doing all of the aspects of my work, because I must provide a space for the whole person to show up and enter the room. And when I do that, what's yielded, both in terms of clinical recovery, where we're able to go in the clinical space, where the information we're able to yield from the research, it goes so much further and it's so much richer. Another guiding principle is reproductive justice. And Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. And it's a theory and strategy that was created really in practice to articulate the needs of communities of color that faced multiple forms of reproductive and sexual oppression. Coined by Black women after the 1994 International Conference on Population and Development that happened in Cairo, Egypt. And Black feminism and intersectionality were key to the formulation of reproductive justice. And reproductive justice is really about momentum building, movement building, and to address the inequities that prevent reproductive health for all. And, it was coined and brought to that conference by women of color, by Black women. And so because of that, it's associated with women of color, right? And the rights of women of color. But that can be a limiting factor in a lot of ways, because it's seen as something like reproductive justice is something that's needed for this group of people. When really what we're seeing in the Supreme Court is that in the absence of reproductive justice, everyone's reproductive rights are at risk, right? So it's not just this group that their reproductive rights are at risk. When we lose sight of the totality of that inclusivity, right? Everybody. So, some of the implications for the Supreme Court right now is that Roe versus Wade is overturned. Courts are going to limit the legal standing to challenge abortion regulations. And just the creation of new standards. So it's really high stakes in the Supreme Court right now for everyone, not just for women of color. But it's been, but in a lot of ways, we've lost sight of that communal well-being when it comes to reproductive justice. And so, while I work in reproductive health, I have to keep in mind, in terms of my work, reproductive justice, because when we ignore the intersectional context, we get bogged down and busied with the downstream tasks that are to the right of this slide. So getting more patients seen, getting health behaviors aligned with metrics of health, symptom management. And so this slide is that like classic allegory of upstream, downstream, right? So someone, some people, you might have heard it in the terms of like fish dying downstream and trying to figure out what's poisoning the waters. You might have heard it as like people falling from a bridge into water, but really the message is the same, right? If we're just looking at reproductive health and not thinking about what's happening in terms of what's needed at a social level, at the societal level, we're going to be on this hamster wheel, right? We're going to be on this hamster wheel where we're always busied with some of these issues. Now, I had created this slide with lots of reproductive health related words and issues, and Tobias goes, "Girl, that slide's too busy. They'll get it." So I took them off. So I hope you can understand kind of what I was getting at, even though what's depicted here is just a few examples of what downstream, midstream, and upstream might mean for reproductive health. And so when we think about reproductive health is service delivery, reproductive rights addresses legal issues, and reproductive justice focuses on movement building, right? All are needed. And even in the fact that, most of my work is downstream, but in order to create effective services and not feel like I'm on a hamster wheel, I keep in mind, and there are still ways for me to participate both in reproductive rights and reproductive justice. And really, this is what we're working for, right? And so I add this slide in here because as something that guides, a guiding principle, something to act as a compass and keep my way. And this graphic has evolved over time. I'm sure you've seen different versions of this, and some have even noted that the picture that there's not a picture of liberation and what liberation might look like. But really what we're aiming for is creating services that allow all people to thrive and be liberated from their obstacles, right? And particularly when I think about this slide in this moment of time that we're in, I always think about, and Tobias and I were talking about this too, I always think about how now more than ever as a result of COVID-19, we know the difference between equality and equity, right? And if you are looking for an example, think about every household getting sent for COVID tests, no matter who makes up your household, no matter how many people are in there, right? That's an example of equality, not really equity, right? Everybody gets the same thing, whatever you, irregardless or regardless of what your family needs. And so the work that I do is in sexual and reproductive health. And while I think, when we think about sexual and reproductive health, most people think about unplanned pregnancies, as kind of a marker of reproductive health, or like how healthy a society or a group or a population is. And when I was looking at just some grounding or foundational stats for this presentation, because I wanted to make sure I was as up to date. The CDC only has up to 2011 in terms of their unintended and unplanned pregnancy. I saw another article from a website, or some other stats from a website that I think extrapolated trends to estimate what 2022 numbers look like, but I didn't include that. I kind of stuck with what the CDC had, but the 2022 trend was around 30%. But the CDC's most recent reports are about half of the pregnancies in the United States are unintended, which is really down from previous reports. But still, some disparities exist, and so some groups still have higher rates those 18 to 24, lower income, certain educational attainment, Black, Black, Black women and people who are cohabitating but never married. Sorry, I wanted to make sure I was saying the right thing there. So when we think about health, most people are thinking about this as, like a marker of whether a community is healthy or not. People also think about sexually transmitted infections. There are about 20 million new infections in the United States each year, and youth bear the brunt of these. And particularly for girls and women, the impact of STIs can carry long-term consequences for reproductive and sexual health. When people think about reproductive health, we also think about maternal health or perinatal health. We think about what are the risks to perinatal health, like morbidity and mortality, perinatal mental health and anxiety disorders, mood and anxiety disorders, and birth trauma, right? So some of the mental health impact of different risks to perinatal health. But sexual and reproductive health is much more than that. And so these definitions and the definitions of the World Health Organization actually encourage us to think about access and freedom from disease or infirmity versus just the risks or the problems to reproductive health. And so I've just added on this, I've added on this slide access to contraception, having access to treatment for STIs, access to fertility treatment, abortion care and family planning access, care that's homophobia and transphobia free, and other things as well. But getting to those freedoms is complicated for many of our clients, patients, and participants who are experiencing their reproductive health in the context of many overlapping factors. And so we know that each of these issues influences reproductive health, and we also know that many people carry more than one or two of just these factors. And so in addition to having levels and layers of these things in their lives, each of these also places people at an increased risk for trauma and abuse and violence. And that in turn impacts their risks for reproductive health. And so when we think about reproductive health in the context of interpersonal and dating violence, we see that girls and young women between the ages of 16 and 24 who experience the highest rate of intimate partner violence, which puts them at greater risk for unplanned and unintended pregnancies and for STIs. So we see higher rates for both in these groups, in this group that's impacted by interpersonal violence and dating violence. Just as a show of hands, I've been talking, and I'm sure you've been hearing conversation, talks about trauma that have included the adverse childhood experience. Using your physical hand or your reactions button, who has heard of the ACEs study? I want to know, like, are we reaching saturation? Okay.
Yeah, I think
so we're pretty close.
Yeah.
Yeah, we're reaching saturation, right? So I've slowly started to like phase out my slide where I like talk totally about the adverse childhood experiences and really just want to talk about it in the context of my purposes of reproductive health. And so when we think about all the different ways that ACEs has been replicated in different communities, what we see is that yes, yet and still, unsurprisingly, ACEs have an impact on outcomes like teen pregnancy, right, and unintended pregnancy. And so what we see here is a dose effect such that the number of ACEs increases the likelihood of a pregnancy, an unintended pregnancy in teen years. So linking childhood adversity to this particular reproductive health health issue, and it's a risk because, especially for teens, because it's linked to lower educational attainment. It has implications for socioeconomic status gains for the pregnant teen. And, you know, as an aside, you know, I also don't want to give the message that there aren't people that actually have their lives benefit from having an unintended pregnancy in their teen years. There are lots of clients that I've worked with that said, you know, it's actually hurtful that people are not happy for me when I say I'm pregnant, right? I'm really excited about this baby. And, you know, women later on will reflect and say, you know, that's when I stopped using, that's when I recommitted to school or my like higher education. And so there can be an effect where people experience a buffering effect as a result of a teen or an unintended pregnancy. However, for many people, it comes with risks that impact their socioeconomic status and educational gains. So I do want to kind of, you know, put that plug in there. I think too often we treat it as kind of a life sentence when some people experience it as positive. And so as another aside, I think as a result, when anybody, in doing the work that I've been doing now with obstetrics and gynecology and with girls and women, when anybody tells me they're pregnant, my response will be, how do you feel about that? Right? I don't get, because there are women I meet in their 30s and 40s that are miserable about being pregnant. And there are girls that I meet in their teens and early 20s that are over the moon about being pregnant. And so it's much more person-centered, I think, to just say, like, how do you feel about that? And then go with that, right? So a little aside. And, you know, I've done some just kind of cursory early work. You know, I describe myself as a reluctant researcher, so I don't want to say that anything I've done is quite groundbreaking, but it has been some interesting stuff that I've done and that I found that kind of speaks to this intersectionality when it comes to reproductive health and context, right? And so we talked about interpersonal violence, we talked about adverse childhood experiences. And so when I first got to University of Chicago, I worked with the Ryan Center Fellows, one of the Ryan Center Fellows on her research project looking at community violence exposure and sexual health of adolescent girls. And so the first part of her study was a qualitative study, focus groups talking to girls about their exposure to community violence and their approach to sex and sexual decision-making. And so some of the themes that emerged from that project were that some girls having sex, reporting that they had sex to cope with the violence that they experienced in their communities, and also to appease their partners. And other girls talked about not really feeling like they had autonomy or the ability to say no to sex in their relationships. The second part of that study, I know this is a little bit smaller, but some of the take homes for the second part, which was a quantitative study, a survey that went out to 644 girls, looking again at community violence exposure and sexual decision-making and behavior. And girls that were exposed to higher levels of community violence demonstrated increased likelihood of experiencing intercourse without contraception, having a teenage pregnancy, and this was even when adjusting for other predictors of teenage pregnancy. And so after that, I was having a conversation with my research mentor, Kate Keenan, trying to think about like how was I gonna kind of continue in my scholarly journey, right, as an assistant professor here. And I, just kind of casually talked about, we're hearing a lot about sexual harassment. I think this was 2017, hearing about sexual harassment a lot. I wonder how this plays out for adolescents, and what does sexual harassment look like for adolescent girls, and how does that impact the decision making of adolescents? And so did a a study using the data from the Pittsburgh Girls Study, and just looked at girls reporting sexual harassment experiences and how that impacted their sexual decision making. And so what we found really briefly was that each age, they were more likely to report sex in the past year if they had endorsed an experience of harassment, to report an STI in the past year. And when we honed in on age 16, they reported increased partners, those girls that reported an experience of harassment. So just some more maybe homegrown data about supporting this idea that there's something going on, right? There's this extra burden at the intersection that's really worth paying attention to. And so we don't have to go far to understand that like race and systemic oppression plays a part in this context too, right? And just as trauma is an overlay to much of what we see with sexual and reproductive health risks, so is race. And so, what we know about communities of color is that there's poor access to healthcare. There's provider bias against in the ways in which services are delivered. And there's patient issues, right? About patients hold myths about different types of interventions and have understandable mistrust and reticence, and even misunderstanding about contraception. And so I add, in this little indented bullet about Project Choice, just a note about access is that access matters, right? Like, and it's not something. So this was a really small, not a small study, but this was one study in one community. But what they found was that when you offer free contraception, and in this study, they were offering access to free access to all types of contraception, but with a little bit more education and hoping to address the myths about LARCs and long-acting reversible contraception. What they found was that when they offered free contraception, the adolescent birth rates significantly dropped lower than the national rate. So we have evidence like this, and still reversible contraception is not offered freely and widely in our communities. And and it's not that free contraception would fix everything, right? We still have bias, we still have myths and mistrust, but we would likely see some really strong effects. And so within race and systemic oppression, we have to understand that there's this historical context of reproductive health. And so, I think as I'm shifting kind of in this talk to think about how do we then work with people, how do we then conduct research from a responsible place, and we have to understand this historical context that people are experiencing their sexual and reproductive health. There was a 2011 essay in Women's Health by Dr. Kamala Price, who at the time that she wrote it was at San Diego State. I'm not sure if she's still there. But what she suggested was that doing academic work in reproductive health, we have much to learn about the reproductive justice activists. We should begin by placing reproductive sexual and sexual health and abortion within the proper historical and cultural, social, political, and economic context. So for example, here I just have images that represent, moments in time. This is not a completely robust, or this doesn't capture everything in terms of the history of Black people in reproductive health. But we see the impact of slavery. We see Marion Sims conducting research on slaves without anesthesia. Consent is a moot point because they're slaves, right? Because they're enslaved women. There's a book called Medical Bondage, which is a great kind of primer and a must read if you want to know more about this historical and racial context in medicine, and particularly in obstetrics and gynecology. And then we see a woman and ostensibly her child talking about with a sign that says no to forced sterilization, which cues us into the realities that in the past and currently, women are being forced to undergo forced sterilization, both in immigration facilities. They're being coerced into sterilization when, you know, being offered lower jail sentences or just probation if they'll undergo the use of IUDs or sterilization. So we see that that reproductive health cannot be discussed outside of this context, both currently political and also historical, right? People are coming into our offices, our research with this history. And a key part of that history has to include controlling images, which is a term that's coined by Patricia Hill Collins. And so many of you on the call like know of this term, know of these stereotypes, but the controlling images were born from a history of like racism, eugenics, that kind of propaganda that poor people, non-white people, and people with disabilities were inferior, and therefore their population growth had to be curbed, right? And they were used to justify the treatment of enslaved women, fueled the nation's complacency with chattel slavery for centuries. It undergirds how we enact our reproductive our legal cases and the supports that we have for reproductive rights for all people. And they also control how we think. They control how we think about people we see, people we work with, and ourselves, right? There are, here are a couple of examples of some of the more stereotypical controlling images: Jezebel, promiscuous, right? The welfare queen, lazy, subhuman, mammy. But there are versions and evolutions of controlling images that position gay men as child molesters, lesbians as just being confused, transgender folks as rapists dressed up as women, right? And so we see that we cannot kind of corner these or say they're only assigned to a certain group of people, because left to fester, they have implications for us all. And I'm kind of going into I think it's really important to understand this concept. So I'm arguably kind of staying in this place a little bit longer, maybe than the talk should, but I find it quite interesting because they impact how we deliver our services, right? There are some people who are coming into residencies still believing that Black people and people of color have different pain tolerances because of their color of their skin, that the color of our skin has anything to do with nerve endings, right? That it's not more than an evolutionary reality, meaning skin, and that race is really just a social construct. It has implications for how we think about contraceptive choices, family planning choices, right? There's really the myth of choice. Here we see Bell Hooks in her quote, "Being oppressed means the absence of choices." The way we think about mothering, we tell white cisgender women, we have all of these messages like that you should be mothering, and yet we're telling it's discouraged for people of color, for anybody else of color. So again, all of these ways that it infuses the ways that we think and enact reproductive health and sexual health. And then, my work has evolved a little bit, and with a research study that if I get to it, I'll talk more about, but about Black perinatal health. And so we see that this intersection also impacts how what we see around the family building, right? And so many people feel in fear of the state taking their children. Many people live in fear of experiencing violence and neglect within the healthcare system, being criminalized in the healthcare system. For example, in many states, if you test positive for drugs, they do a drug test for you when you're delivering. If you test positive, they will they may take your child from you. Right. And so we're de-incentivizing accessing mental health care, accessing healthcare, and we're criminalizing accessing healthcare for some people. So lots of different things. I won't spend too much time here. If anybody wants to know more, we can go back to this slide. And then we see this playing out in our disparities in Black perinatal health. So being 4 times as likely to die from causes related to pregnancy, highest rates for CDC's severe maternal morbidity indicators. Okay. So let's take a deep breath, and really I'm talking about me, because I want to talk about how, understanding if those are my guiding principles, if they're my guiding principles because of the context in which people experience their sexual and reproductive health, how then does all of that influence service, right? How does it influence clinical work? How does it influence research? And other aspects of taking care and partnering in healthcare for our communities. And so I've really been drawn towards this idea of this evolution from trauma-informed care, right? Trauma-informed care has been such a huge part of my work and my lexicon, and I've really been kind of in awe and open to how it's evolving, right? Everything has to change. That's the constant, right? And so it's been evolving from trauma-informed to responsive, and now to just something I'd like to talk more about, which is liberation and healing-centered practices, which I hope we can spend some time in discussion about. I'm going to put an article in the chat that I just would love for people to kind of look and have as reference as we talk and open up discussion at the end. So again, we all know the adverse childhood experiences. And so one of the evolutions of the ACEs study was understanding that these experiences happen also in the context of communities that have adversity and adverse community environments. And in addition to this evolution, is this idea of in moving away from thinking about post-traumatic stress disorder, which where the problem exists in the individual's body and mind, and the burden is to fix, and the burden to fix is the person's, right? The responsibility is the person's to get help, to be open to help, et cetera. And moving towards thinking additionally about PTSE, right? So persistent toxic stress exposure, excuse me. And so the problem is housed in the environment. The burden is shared to address, right? The burden to address this is shared. And so this article that I put in the chat talks about healing-centered engagement. And so these are a couple quotes, but again, they're, the author talks about shifting from trauma-informed and why, right? And makes an argument for what are some reasons from evolving and growing trauma-informed as a framework. And so in this quote that I'll just read, current formulations of trauma-informed care presume that the trauma is an individual experience rather than a collective one. And the term of trauma-informed care runs the risk of focusing on the treatment of pathology rather than fostering the possibility. And my mentor, I was asking her I wanted to borrow a slide of hers. I was like, do you mind if I use this slide that you use? And she said to me, she was like, Candice, and she's focusing on some life-term projects. She's got her perspective as what are the things that what's the legacy I want to leave for my career? And so she said, Candice, no one is coming up with anything new. We're all evolving what's here. She was like, take the slide, make it yours, right? And I found that so freeing, because I think, especially in academia, we're kind of being forced to what's your unique take? What's your innovation, right? And in a lot of ways, we're just rehashing and repackaging things so that people can digest these core issues, right? And so that people can really understand and make use of them. And so that may be what this article is doing. But I liked it, right? And I liked the curiosity that it stoked in me. And it also aligned with this, I want to talk to girls and young women about enjoying sex. I want to talk to girls and young women about, experiencing their lives child-free if they want to, right? And not looking at pregnancy as something to be scared of, not looking at it as, as not looking at these things as obstacles that you've got to, ditch and dodge throughout the course of your life. And so this idea of healing-centered engagement and fostering possibility, I don't know, it got me. So I think this is worth the read. I put it in the chat for you. And so what that kind of has encouraged me to do is think about what are my practices and how do I practice then with liberation in mind? And so I don't want you to think that I'm talking about liberation as I'm going to liberate people or I'm going to be some kind of like Moses, right? But what I'm talking about is liberating myself from thinking that has enacted harm on people that I've worked with, or that will enact harm on populations that I'm studying. So practicing with liberation in mind is really how I'm thinking about that. And so, the next couple slides are I'm going to go through quickly because they're just some things that I'm percolating on as I think about practicing with liberation in mind. So this idea that words matter, right? When I work a lot with people that have abortions, and so on our forms, we have elective abortion, right? Or, we talk about the choice to have an abortion, and that's really harmful, right? And so I want to encourage you to think about to use induced abortion, not elective abortion, and to talk about the decisions that people have to make, right? Because we choose what color car we're going to have, right? But not everybody has all the options that other people may have. So in fact, people are making decisions with the options that are in front of them, right? And so if you're talking to somebody who has just been diagnosed with a fetal anomaly, is being placed with this horrible decision about going through with her pregnancy, or making a decision to have an induced abortion, that's not something she's choosing, right? She doesn't elect to have that, but she's making a decision based on lots of factors that will have implications for her and her family, right? Okay. And practicing with liberation in mind also emphasizes the right to values. It encourages me to have a continuous evaluation of my policies and procedures for accessibility, right? And not just do it as a checkbox. It challenges myths about reproductive justice. And it reminds me to resist, right, that, like I mentioned, the allure of choice, controlling images, heterosexism, mothering as an imperative, et cetera, et cetera. And so this is my image for clinical work. So I had to do the telehealth since that's been my reality for a little bit, right? That might've been different a few years ago, right? And so when I think about researching with liberation in mind, some things that I think about are nothing for us without us, right? Really having people from the community at the table when you're creating your proposals, when you're writing up your procedures for your research, having people weigh in. What would that be like, right? Really avoiding the appearance or the engagement in extraction, right? I'm going to go into the community, extract what I need, and not give anything back, right? Really kind of thinking about how you do your research. I'm not going to talk about that too much. Well, and so the other thing I think about is, liberation in mind has also informed how I think about relationships, because instead of thinking about, if I'm doing a research project around, I've done one about sexual decision-making in adolescent girls. I'm also doing a research project about Black women and their experiences of, their awareness of maternal health risks and disparities, and also how they want to talk to their providers about that. And I think if I was just, and so I want to think about how can relationships foster engagement, health, thriving, and that just feels like research that I can engage in a healthy way, right? It's healing centered, right? So I really want to focus on the healing. So I want to end my presentation with a minute and a half of, I think, a song that I think represents where I'm at in terms of how I want to approach and think about the work that I'm doing. It's our very own Jamila Woods, who is a Chicago native, and hopefully this sound works.
It is our duty to fight for our freedom.
See, she's telepathic, call it black girl magic. Yeah, she scares the government, deja vu a tough man. We go missing by the hundreds. Ain't nobody checking for us, ain't nobody checking for us. The camera loves us, Oscar doesn't. Ain't nobody checking for us, ain't nobody. They want us in the kitchen, kill our sons with lynchings. We get loud about it. Oh, now we're the bitches. Look at what they did to my sister. Last century, last week. They put a body in a jar and forget her. They love how we repeat. Look at what they did to my sister. Last century, last week. They make her hate her own skin, treat her like a sin. But what they don't understand, but what they don't understand is, but what they don't understand, see what they don't understand. See, she's telepathic, call it black girl magic. Yeah, she scares the government, deja vu a tough man. She don't give up.
That's the energy I'm going into 2022 research and clinical work with. And so I just hope that stoked some ideas. I hope you've had a chance to look at the article that I put in the chat. And I just want to open it up and have a conversation. Thank you.
Thank you, Candice, for presenting. I want to make some space for you to talk a little bit more about this wonderful funding that you received, and how your presentation, what you presented is like the aspect of liberation, I guess. How is that, what does that look like in your proposed research that you have, that you just recently got funded?
Well, you know, I think a fine line to walk when you're talking about Black perinatal health is, how do you bridge the gap between there's this risk and then addressing the risk, right? And moving towards, and so I guess I felt like there was so much information about increased risk for Black women, you know, increased maternal health risk. And first I wanted to know, like, I think that women are more aware of it now than ever, but I don't know that, right? So are Black pregnant people really aware of the risk, of the increased risk? But there's this other reality that, like, for most other conditions, when you have an increase of awareness, it decreases your risk, right? Because you can take steps to address the things that put you at higher risk. So cardiac health, right? You can lose weight, you can exercise more. For certain types of cancers, you can, you know. But we keep seeing the numbers for Black moms, right, or Black pregnant people go up in terms of severe morbidity and mortality. So what's happening there, right? And so I wanted to know, like, is there an awareness? Are people scared? And how can we leverage the relationship to begin to address that? And so, you know, so I think it was kind of shifting from trying to shift from and just understanding more what was happening. And I think in terms of actual, like, research procedures, I created this survey of awareness based off of American Heart Association, like a survey that they created, the American Heart Association created for women, addressing, asking about their awareness of women's cardiac issues, right? But then what we did was, so we created this, but then what we did was we brought groups of women together to take the survey and say, what do you think of this survey? Did it freak you out? Like, what would you, like, if you were doing a research study and you were asked to take this, how would you feel about it? And so I think just even in that little decision, I think that's a piece of bringing people into their, practicing, freeing myself from practicing from a really myopic kind of old school approach.
Mm-hmm.
I have a question for people.
Yes, go for it.
So, one of the things that I like about like healing-centered engagement and this idea of, thinking about persistent toxic stress exposure is this focus on community. But I'm curious if what you think about making a shift like that, and what maybe gets left out, and how do you think about balancing a conceptualization of post-traumatic stress disorder, and integrating the focus also on environment? Like, is there a way to do both, and what does that look like? Do you think?
Yeah, that's a great question. I often like to think of PTSD as really post-traumatic stress reaction. It's normal, even if it's for 30 days, which is the acute version. I know in the work that we do with working with families exposed to community violence, and oftentimes for the population that we're serving, it's chronic. And so we have to use that diagnosis if it's applicable. Most of our kids don't get the PTSD diagnosis because it's not really developmentally sensitive, and that's why they miss the criteria sometimes. But either way, the treatments are the same. But when we, as part of our treatment, is this focus on healing and resilience, and contextualizing the experience of community violence at not the individual level, but we actually talk about it as a structural issue, and it happens for a reason, and it happens a particular demographic. And I know we have a number of our team members, past and present, on this this talk today. But so to make that shift, to go from, you said persistent trauma, the post-persistent trauma, I'm sorry, how did they go?
I'm muted. Persistent stress exposure.
Persistent stress. Yeah. So, there's terms like continuous traumatic stress that we share with our families, like that. I think that might be similar to that. I don't know how the persistent construct is defined actually, but continuous traumatic stress is like, you're in a system where you're constantly re-exposed to the same situation, which over again, and it is coming from a systems point of view often when people sometimes use that. But to make that shift, it's something I would want to think more about. I feel like we do that anyways, because we always contextualize, at least the kids that we work with, in a very structural, we have like a structural lens when we present this information, and we give families an infographic explaining, like, instead of saying like on the after visit summary, oh, you have PTSD, here are the symptoms. Our after visit summary is not like that at all. It is very grounded in systems and structural explanations as to why this is happening, so they have a better understanding. And then also we still have to talk about understanding their reactions, but also what are the things that they can do to help recover as well. So I don't know if anybody else wants to add to the team members that I work with. They want to add to that or have it talk about it in a different way.
I think Royce is unmuted.
Uh-huh.
Yeah, I think there's a lot to it. And I think some of it we do intuitively, and then some by design. So like the idea of an individual clinician attempting to help cure somebody of PTSD is another kind of trauma for the clinician too, right? As opposed to a whole team with kind of multi-level support. So I think of some interventions we've done where there's like a violence prevention worker working at the level of the school, and she puts together the Zoom so we can meet with the, the client and their sister and their mom all at the same time. And it's not very clinical. The diagnosis becomes kind of superfluous, and mostly what we're doing is kind of orchestrating social support. And then another example, I'm trying to do this without blowing any HIPAA. So we had a person come in post-suicide attempt into the ED, was re-triggered by the ED, and technically is supposed to be hospitalized. But watching the person get re-triggered, clearly the answer is just a discharge, because this person is talking about not wanting to die, but rather kind of retrieving their life and putting things back together. So the decision is made to discharge, right? So that's kind of recontextualizing the mental illness as a more in terms of, stopping the trauma, getting their life together, focusing on very basic things, and focusing a little bit less on this question of mental illness. So those would be some of my thoughts.
Hey, Ms. Sherry.
Yeah.
Go ahead.
Well, I was just going to say, the perspective of thinking about the clinician as well as part of the system.
Yeah. It has to be, I mean, not to, talking about trauma-informed care, as you mentioned some of the limitations, but I think, our team, we definitely include the pieces that were criticized as not being included in trauma-informed care. But, when we do talk about trauma-informed care, it has to be the providers, the systems, the policies, and about the patient, right? So it has to work together. If it's one or the other, then it's really not trauma-informed care. It has to be coexisting. So, but I wanted to point out Ms. Sherry is working with Jen Wright's team in New York City. I don't know if you see in the chat, but I forgot.
Yeah, Ms. Sherry, you unmuted.
Go for it.
Oh, excuse me, ignore the video. What was I gonna say? So we're just trying to figure out what that might look like. So we worked with New York City over the summer to train a whole bunch of parents. Actually, was training 800 parents. And they got a grant, and what they're trying to do is get at least one parent lead in each school to have capacity and understanding around trauma, so that they can advocate for kids in the school who might not be being served well. And then, so that's what we did during the summer. And then the New York City is working with Jen Wright's team to do a pilot in 20 schools where they're taking some of the parents we trained and then now training them on his model. And then they're trying to, and then a staff member from each school are all taking his training together. And then they're going to try to collaboratively, and we're now back in this process, collaboratively create some kind of collaborative parent staff together, intervention support systems for in the schools. And it's just really open. It's just like, well, when we make it open and say parents and staff together in a school, what do the students in the school need? And it's schools that had a high level of exposure to stress and trauma, high crime neighborhoods, all of those things. So what it will look like at the end, we have no idea. But we built some parent capacity in the summer. We're doing now 4 more sessions to build parent capacity more. And then it's kind of like, if we build parent capacity and then send them into schools to collaboratively develop something with school staff, what might it look like?
Mm-hmm.
That's it. I have no idea what the end will be, but that's the goal.
Yeah. Well, thanks for sharing that, Ms. Sherry. So hopefully we can continue this discussion beyond this hour. I know we've gone over, but we do have these collaborative formations that have grown out of the trauma interest work groups. I encourage people to continue to connect outside of this space, and we'll have to stop. Thank you for your extra time. Thank you, Candice, for taking the time to present and share your work. And yeah, we'll see you all at the next Brown Bag series that we'll have in the spring, and just look forward for other events that we're having in addition to the Brown Bag series. So take care, everyone, and have a great rest of your day. Bye.